It's just preparing to stream.
Okay.
Okay, and we are live. Hello, web shadowers. Welcome back. Thank you all for joining us this afternoon. Today, we have the pleasure of welcoming back Dr. Alyssa Cole, who will be teaching us about PM&R and cancer rehabilitation. As always, please remember that the Google form will be posted in the chat and in the description of this video when the session is over. With that being said, Dr. Cole, you can get started whenever you're ready.
Thank you. Thank you so much for having me back, actually. And yes, it's a little bit of a mouthful. So PM&R stands for Physical Medicine and Rehabilitation, and my subspecialty is cancer rehabilitation. I love doing these kind of shadowing sessions. So if you attended my last one, you might see some repeat slides, just because I want to go through my background a little bit for those of you who haven't seen this presentation. It is a different case, so please stay tuned. And if you have any questions, I will leave my contact information at the end, but I am also active on social media, so feel free to reach out. I am at dr.cole, doctor.cole, C-O-L-E, on Instagram and TikTok. All right, so for the outline, I will briefly discuss my story as well as osteopathic medicine, because I am a doctor of osteopathic medicine, why I chose the field of PM&R, more specifically, why I chose cancer rehabilitation, a case example, and some key takeaways, as well as some medical advice. So a little bit about my story. I was born, raised, and educated in New England. I earned a dual degree in classics and biology, so combining the arts and sciences is a huge passion of mine. I also graduated from an osteopathic medical school, as I mentioned. I actually graduated from the University of New England College of Osteopathic Medicine. So it was right up in Maine and right on the beach. And then I attended physical medicine and rehabilitation residency in Philadelphia. Once I completed this, I pioneered the first cancer rehabilitation fellowship program in Philadelphia. The reason I chose osteopathic medicine was because I really aligned with the osteopathic medical philosophy of treating the patient as a whole person and not just the disease, and really understanding kind of the osteopathic tenets of self-regulation and interconnectedness of structure and function with the human body. And this is one of my favorite quotes by the founder of osteopathic medicine, Andrew Taylor Still. So he was an MD and he founded the DO school because he felt like allopathic medicine just wasn't the correct approach that he wanted to follow. He wanted something that offered a more holistic view of treating patients as well. And his quote is, "To find health should be the object of the doctor. Anyone can find disease." And I mention this because I'm also a strong advocate of the DO philosophy, and I helped to put together the DO Proud campaign with the American Osteopathic Association. I also have several resources on my blog, if you're interested, that shed a little bit more light on what being a DO is and what the osteopathic medical field is. Now, moving on to why PM&R. So why physical medicine and rehabilitation? And I love this comic because I think that it's something that can certainly be used in all specialties, but definitely relates to PM&R. I did use it in my last presentation for web shadowers, but it's just, it gets me every time. So it says pain somewhere, and then the doctor asks, "Where is your pain?" And the patient says, "You're the doctor, you tell me." So we are the doctors known as physiatrists. So PM&R, or physical medicine and rehab, we also go by the term physiatrist or physiatry. And our goal is to optimize function for patients and help improve and maintain their quality of life. We have a strong sense of anatomy, neurology, as well as the musculoskeletal system. So certainly being a doctor of osteopathic medicine, we learn osteopathic manipulative medicine and are able to essentially treat patients at our fingertips. And so having a strong sense of anatomy and neurology and the musculoskeletal system can really help in this field of PM&R. And then we also have several different areas that we can subspecialize in, including spinal cord injury, traumatic brain injury, palliative care, and of course, in my field, cancer rehabilitation. There's also sports medicine and pain medicine. So for me, as a cheerleader at heart and growing up, I really wanted to be the doctor that motivated patients to move forward in their progress mentally and physically. I do remember there was a stroke patient who was not able to walk across or actually stand up about a month before seeing her. And when I saw her, she was able to walk across the room and hug her children. And that was after being treated by rehabilitation specialists and receiving physical therapy and occupational therapy. So I just realized, I wanted to be the doctor that could help her do that. And now more specifically, why cancer rehabilitation? So often these patients are underserved and undertreated. There is a huge gap in their care from a rehabilitation perspective. And with so many advancements in cancer treatments, also comes the potential for increased survivorship. And as patients, live longer, they are more likely to have more complications. So this could be due to surgery, it could be due to chemotherapy or radiation, or even the cancer diagnosis itself. So there is a growing need for these rehabilitation specialists who can recognize the issues that are most common in these patients, from nerve damage to swelling and lymphedema to muscular issues. And I'll go through a few more examples later on. But in terms of treating these patients, we have to be able to recognize this while still not getting tunnel vision and automatically assuming, whatever their complaint or issue is due to their cancer. These patients also, they really have a new lease on life, and they're very appreciative and receptive to medical recommendations. For me, it's given me a strong sense of fulfillment with treating this population. I was actually recently asked, what is the most satisfying part of treating these patients? And it's often, when they come back and follow up with me and say, that their range of motion has improved because of whatever intervention I provided or recommended, and they're able to get back to work, to get back to their activities that they love doing, and knowing that I was the physician that helped them kind of change their life around so that they could return to doing what they love to do. It's a very rewarding feeling. So again, why cancer rehabilitation? This goes into some of the example diagnoses that I often see or chief complaints that I often see. Weakness and pain, fibrosis and scarring. So when things get really tight, as well as trismus, so having difficulty like mouth opening, dystonias and spasticity, also when the muscles can get really contracted. And of course, pain, often in the joints, the neck or the back, neuropathy, so nerve issues, as well as muscle cramps, overall fatigue, especially in the cancer population, deconditioning, lymphedema, like I mentioned earlier, so swelling, late effects of radiation therapy, cognitive or thinking issues, bowel and bladder issues, and then depression and anxiety, especially as it relates to physical and cognitive function. So that really emphasizes that, this is where you have to treat these patients as a whole person, body, mind, and spirit. And so how do we do that? So of course, we as cancer rehabilitation specialists focus on the neuromusculoskeletal evaluation and performing our physical exam. We also can provide medicine, so pharmacologic management. We can do ultrasound guided injections to the joints. We can also do Botox injections. You might be familiar with Botox as treating wrinkles and cosmetics, but it's actually also used for helping to treat contractures and spasticity and helping to relax those muscles. and then trigger point injection. So any sort of like knots that you get in your muscles can actually sometimes be diagnosed as trigger points. And that we can treat with an injection, usually of lidocaine, so like a numbing agent, and it helps to kind of break up those muscle fibers. Also orthotic and prosthetic equipment evaluation and management, and then overall having a multidisciplinary approach. So working with the therapists and interventionalists, with specialists like palliative care and the oncologists. And this is all to improve function and quality of life, to help decrease pain, especially chronic pain, and help patients return to activities that they love doing, to help them return to work and living life to their fullest. So moving on to our case example, we have a 52-year-old gentleman with a history of tonsillar cancer who is presenting for neck pain and shoulder weakness. He used to be a carpenter, but he has not been able to work due to his shoulder pain and difficulty moving his arm. So what questions would you ask? And I think there's a chat going. You're more than welcome to chime in, but I'm going to go right into it. It's similar to the previous case example that I had given in terms of questions that you would ask, because these are questions that you're going to ask every patient that comes in. You want to think OPQRST. So onset, when did it start? Palliative versus provocative, what makes it better, what alleviates it, or what makes it worse, what exacerbates it? Quality, so you want to describe the symptoms. Is it sharp, dull, achy, burning, stabbing? Radiation, how do your symptoms travel? Is it just localized to the neck? Is it radiating down your arm? Is it going to your shoulder? And then severity, usually we do this on a pain scale of 1 to 10. So that would be like 1 being a hangnail and 10 being the worst pain you can imagine. Although some hangnails can get pretty severe. And then timing. So is there a certain time of day or night that your symptoms feel better or worse? Is it constant? Is it happening spontaneously? Or, is it lasting for an hour? Is it lasting for a few seconds? Really helping to understand that and clarifying that can help with the diagnosis. So for our patient, his pain location was in the right neck and shoulder, as well as the upper back. He described it as stiff and achy. He rated the pain intensity as 8 out of 10, and it began 2 years ago after his surgery to remove his tonsillar cancer. So he's been living with 8 out of 10 pain for 2 years, and it took 2 years to present to the cancer rehabilitation clinic to help alleviate this pain and treat him. Exacerbating factors, so trying to move the neck and right shoulder worsens his pain. And alleviating factors, what makes it better? Laying on the back helps. It takes pressure off of the neck and the arm. And current medication, so he is being treated with gabapentin, which is a nerve pain agent. It's also known as Neurontin, as well as Advil, which is an anti-inflammatory. He was previously on opioids, but he was able to be weaned off of those. So a little bit about his cancer history. He had been diagnosed in 2017 with right tonsil squamous cell carcinoma. He underwent a transoral robotic surgery with a tracheostomy. So that's where they create a new airway and they put a hole in the trachea. And then a right neck dissection. So they opened up the neck and were able to kind of dissect to remove the tumor. A partial glossectomy. So they partially removed a piece of his tongue. And then a free flap reconstruction. So once they kind of open everything up, they have to put it back together. And the way that they do that is they take a flap from a different site in the body and place it over so that they're able to kind of reconstruct the area and put everything back together. So this took place in May of 2017. He had radiation to the bilateral, so both sides of the neck. This lasted for 7 weeks and ended in August of 2017. And then he underwent chemotherapy with cisplatin in August of 2017. And cisplatin is actually known to cause sensory changes and nerve pain just in terms of once you've been treated with this. So that's most likely what he's on the gabapentin for, that agent I mentioned earlier for treating nerve pain. Now, moving on to his neurologic exam. So he had full left upper extremity strength, upper extremity referring to the arm. So his arm strength was full and intact on the left side. But on the right side, he was very weak with elbow flexion, so bending the elbow, elbow extension, straightening the elbow, and then wrist extension, bringing the wrist back. I don't know if you can see it. It might be, there we go, bringing the wrist back like this. He had decreased sensation over the area of the surgical site. And this is very common to see, especially as scars heal. Oftentimes, what's called cutaneous sensation may be sacrificed in the healing with the scars. And it can essentially lead to numbness or overall just decreased sensation there. And then on his musculoskeletal, so muscle and bone exam, he had right neck tightness. This was known, or also known as fibrosis or contractures. He also had tenderness over the clavicle. So that would be the bones in front in the neck here. And then his neck muscles, including one muscle called the sternocleidomastoid. We often abbreviate it as SCM, but you can see the top picture is the sternocleidomastoid. Essentially, if you break it down, this is the classics major in me, stern meaning sternum, cleido meaning clavicle, and then mastoid, which is the mastoid process up here. That's where it gets its name from. And then there was limited range of motion in the neck toward the left, and there was atrophy. So the muscles were essentially shrinking in the right trapezius. And this shows an example of the trapezius muscle. It's that big fan-like back muscle that we all have with lateral scapular winging. And so when it's weak, it means that the scapula or the shoulder blade is not able to be stabilized against the body, and it will wing out. So why do we care about the shoulder? The shoulder is the most mobile joint in the body. It's crucial for performance of ADLs, also known as activities of daily living, so what you do on a daily basis. It is used as a weight-bearing joint, and it's used in mobility and transfers. For it to work properly, it requires elegant coordinated movements between the ball and socket joint. So you think ball and socket, as you can see in the picture here, as well as the muscles, the tendons, and the labrum, which is a fibrocartilaginous structure, kind of like encapsulating the joint, in the joint. And it can also be the shoulder can be affected in several cancer conditions. So those include tumors affecting the brain and spinal cord, breast cancer lymph node dissections, which results in axillary cording. So under the armpit, you can actually get lymphatic vessels that form rope-like tissue texture. And then spinal metastases, where the cancer will spread to the bone, and that can cause skeletal abnormalities. Radiation that can cause shoulder weakness or tightness. And then neck dissection, like our patient had, which can lead to a spinal accessory, otherwise known as cranial nerve 11 palsy. Now, this picture just goes over kind of what the physical exam would have looked like on our patient. This patient, it's specifically referring to the left side, and our patient's complaints are on the right, so just keeping that in mind. So the first picture, it reveals the winging of his left scapula. You can see it's displaced laterally, laterally being kind of out to the side. And then there's severe atrophy, again, muscle shrinkage of his trapezius. And he also has this asymmetrical neckline and drooping of the shoulder girdle. I think you guys can see my arrow here. So you can see here as well, kind of that drooping of the shoulder girdle and the atrophy of the trapezius. So what do we think is most likely injured? Is it the nerves? Is it the muscles? Is it the bones? Or could it be the lymphatic system, such as swelling from lymphedema? in many cases, could it be a component of all of these? Could this be a multifactorial presentation? So I'll let you guys answer in the chat, but I'm going to keep going. So back to our case example. So in order to kind of figure out what could be going on, one of the best ways to better understand this patient's anatomy is to look at the operative report. And in the operative report, the surgeon mentioned sacrificing the spinal accessory nerve, what I mentioned earlier, cranial nerve 11. And this muscle innervates the trapezius and the sternocleidomastoid, those two muscles that I had mentioned previously as well. So for our assessment, we diagnosed this patient with a spinal accessory nerve palsy or injury, and postoperative, as well as radiation fibrosis of the neck muscles and soft tissue. These are very common issues these are issues that are commonly seen and lead to shoulder pain as well as limited range of motion in patients. And research has actually shown that spinal accessory nerve function can be affected even when it's preserved. In 2001, there was a study done that showed shoulder pain was clinically present in 70% of patients who had undergone a neck dissection. And in 2000, it was reported that 100% of patients had shoulder pain and 80% had shoulder drop after a neck dissection surgery. There was another research article that came out that showed, these patients can have gradual improvement months after their surgery, but the recovery may not be full. So what was our plan? We wanted to focus on pain reduction, so helping alleviate this patient's pain. And that was with medications as well as injections. So I mentioned earlier those Botox injections that many of us are familiar with from a cosmetic standpoint. It can actually be used to help relieve that tightness that this patient was having in the SCM or sternocleidomastoid muscle, as well as some tightness that was found in the trapezius. We were also able to correct his mechanical dysfunction. And so that was with physical therapy, helping to kind of move the joint around, stabilize everything, stretching everything, strengthening the shoulder, really improving his flexibility and range of motion. And then activity modifications and changes. So helping him understand proper lifting as well as transferring activities to avoid. And treating contributing problems, so postural issues. Let me see, there's just a couple things popping up. Oh, okay, there were a couple of questions coming through. So let me see, I just wanted to make sure you guys could still hear me. I'm going to answer the questions at the end, so I'm happy to do that, but I'll continue kind of talking about the plan first. Treating contributing problems, so posture, correcting posture, as well as treating any concerns with something like lymphedema, so swelling, like I mentioned, if the lymphatic system was compromised. And that can often happen if there is lymph node removals, which is very common in these surgeries. So overall, thanks to the Cancer Rehabilitation Clinic, this patient not only received a formal diagnosis, but we were able to address his therapy needs as well as reduce his pain. And at follow-up, he reported improvement in neck range of motion and pain reduction during both the day and at night. And he also noted he had more refreshing sleep. So the key takeaway, it took this patient 2 years to present to our cancer rehabilitation clinic, despite progressive symptoms, having restriction, pain, and even his inability to return to work. There is a huge gap in the care for this population. So please help us fill it by becoming a cancer rehabilitation physician. And a little advice for future physicians. Remember, it is a marathon, not a sprint. I said this last time, and I just can't emphasize this enough. I'm still running, but it's the long haul. So be prepared, but it's going to be worth it in the end, I promise. And then I also included this in my last presentation, what studying medicine is really like, the dream versus the reality. It is a little bit like this, not to scare you, but I promise it gets better. And it's, it is what it is. And it's also, what you put into it is what you'll get out of it. But also certainly prioritize self-care and mental health. And finally, this is a timeline for kind of what to expect when it comes to applying for medical school. I think this is really helpful. It helped me as well. So I hope that it helps you in kind of figuring out deadlines and when to request, for example, when to request letters of recommendation, and also getting in any like shadowing experiences. So thank you everyone for attending. Again, I am available on Instagram if you have any questions or you want to reach out. You can find me at dr.cole. And then I do have the blog that I listed here, dailydoseofvita.blogspot.com. And also my email. If you're interested, I am a medical school admissions consultant, so I'm happy to provide more information on that. All right, and let me see, I'm gonna stop sharing and I'm gonna take a look at the chat. Oh wait, actually, maybe I will, I'm trying to think. I'm gonna stop share, but I can always reshare if someone has a specific question on one of the slides. So during a neck dissection, is muscle tissue also dissected or is it preserved? That's a great question. So certainly an oral maxillofacial surgeon, head neck cancer surgeon can provide more light on this and more information. But from what I've seen, yes, the muscle tissue is also dissected. If it's unable to be kind of retracted or pulled to the side. And in some cases, if the cancer has invaded the muscle tissue, then they will have to resect that. Resect meaning remove. Okay, have you ever had a case where no one could figure out where the patient's pain was coming from, and how do you deal with this? Yes. So, a lot of times patients will present with certain symptoms that, well, not a lot of times, but oftentimes, if that is the case where we're really not sure, it's something that we would call idiopathic. And in cancer patients, like I mentioned, pain itself, which actually could be a whole other lecture, it can be physical pain, it can be mental pain or emotional pain, and it can also be spiritual pain, and that can manifest in many different ways. And so, if we can't necessarily provide an exact diagnosis or reason for why they're having pain, even so, our one of the ways that we're able to treat this is, certainly listening to them to try and figure out, what else could be going on. And like I had mentioned earlier, trying to delineate, can they describe the pain? To help us figure out, could this be nerve pain? Could this be muscle pain? Is it tender when we touch it? Is it burning, electric, shooting pain? And if, everything is starting to kind of form a picture that doesn't quite add up to one specific diagnosis, it could be that we have to, treat the whole body. For me, one of the interventions that I found the most helpful, especially for cancer patients, is osteopathic manipulative medicine. A lot of patients who are in the cancer population, they don't really like taking medications, which is kind of interesting because they're taking medications to help treat the cancer. But I think that they've found that, with so many side effects, for example, from chemo, they really want to try and cut down on their medication regimen. And so being able to offer OMM as kind of an adjunct treatment has been really helpful for patients who want to kind of stay away from anything oral. Another modality that I really like to use would be, if I do give a medication, it would be like a topical medication, something that they don't really have to take by mouth, as long as they're, of course, not allergic to it. And then certainly, any other therapeutic modalities, using ultrasound, as long as it's not over a cancerous lesion, and then heat and ice. There's also something called a TENS unit, which can help, especially with nerve pain. Okay, so I hope that answered your question. All right, so there's another one. What do you think attributed to the patient delaying their visit to the doctor's office? Was it medical illiteracy? Great question. Was it depression, which prevented the patient from seeking help? So I think that a lot of patients I see in terms of their delay to coming to specifically a cancer rehabilitation specialist is because it's such a small field. Not many people know that we exist. I mean, physical medicine and rehabilitation in and of itself is a small field. I'm sure I can count, I have countless encounters where patients, either didn't know what PM&R stood for, had never heard of a physiatrist, and especially had never heard of cancer rehabilitation specialist. So I think that was most likely one of the biggest reasons. But the other is that a lot of the patients that I've seen, they have, I mean, maybe they don't have necessarily a high pain tolerance, but they have a high tolerance for what they think is now the new normal. And they often don't realize that, this is something they could be treated for. I don't think they realize that, there are ways to help alleviate these, and they try to just live with it. So I think it can be a mix of both. For this patient, I don't think depression necessarily came into play with his delay in presentation, but certainly, there are patients that can be limited in kind of their involvement with the medical community if they are feeling depressed, and that's why it's so important to ask about patients' mental health. Okay, how easy was it for you to find a residency as a DO? Is it any harder as a DO than an MD? So the residency programs have actually merged at this point. And so, I mean, at least when I was applying, there was no difficulty in finding a residency program for me or even my fellow classmates that I had heard of. I think that overall, the more competitive the specialty is, whether you're a DO or an MD, it's going to be difficult. Certainly, if you wanted to be a neurosurgeon or a plastic surgeon or even dermatology, I think, that finding a residency, whether you went to an MD or allopathic medical school or an osteopathic medical school, you really want to make sure that you have the clinical experiences, as well as, if you can, maybe research to support why you feel you would be a good fit for that specific specialty and residency program. Okay, are physiatrists involved in the post-operative care team, or do patients typically present to your clinic months, years after cancer treatment? Great question. So I actually forgot to mention this, but I am now in Virginia and I have officially started my role as an attending physician. So I'm done my training. And this is actually something that we are really working toward, not just post-operative care, but pre-operative. So we are seeing patients, especially breast cancer patients, before they even undergo surgery, so that we can, in a way, prehabilitate them. So get them a little bit stronger before they undergo surgery and potentially decline in their function. So that, if they do decline, they're almost hopefully back at their baseline rather than being even lower than their baseline. It also gives us a chance to educate these patients on what to expect in terms of side effects after the surgery and ways that we can manage and treat those side effects. There are some patients that do present, though, to our clinic years, months later after their cancer treatment. And that, again, plays into the role of survivorship, and that these patients, they are surviving much longer. And with that comes complications. There can be delayed complications and side effects from all of their treatments, especially radiation, even surgery, and again, chemotherapy. How does your daily work and lifestyle compare to that of other specialties? I mean, I think, it's definitely not as demanding or fast-paced as maybe like surgery or in some cases, maybe emergency medicine, although there are certainly pros and cons to each specialty's work-life balance. I know, for example, emergency medicine, they have shift work and they're not on call, whereas physical medicine and rehabilitation, we don't have specific shifts and we do take call. So I think certainly asking other specialties to kind of compare is a great way to figure that out. But I will say that the lifestyle for PM&R is very well balanced, and a lot of physical medicine and rehabilitation doctors have several hobbies and passions outside of medicine too. Of course, for me, it would be social media and getting to teach all of you. And then let me see, given that the sternocleidomastoid muscle was affected, wouldn't the patient also present with respiratory issues? That's another great question because it is an accessory muscle use. So he didn't have any respiratory issues because his respiratory system was working fine. But, certainly if he was becoming hypoxic, so he was having difficulty breathing or low oxygen, he would be at a disadvantage if he did need to recruit those accessory muscles to help him breathe. Okay, what advice would you give to a pre-DO student? Is there anything different than what you would recommend to a pre-med student? So for a pre-DO student, I would highly recommend shadowing a DO because they can talk to you a little bit more about what sets DO philosophy and medical schools apart from the allopathic or MD medical schools. And they hopefully can also show you some osteopathic manipulative treatments so that you can better understand, what it is, what OMM is, and what we learn and how we can implement that into our practice.
Thank you so much, Dr. Cole. I think that was all the questions we had coming in. Thank you so much for a wonderful presentation and for taking the time to answer all of our questions today.
Absolutely. Yes. Thank you for having me. And I wish you all the best of luck. And I hope to see you someday working as a colleague.
Thank you so much again. And for all the viewers, the Google form has been posted in the chat and will be in the description shortly. So you have 30 minutes from now to fill that up and fill that out. And once again, thank